Good evening. I'm Dr. Chris Shaffrey, and I'm going to be speaking to you today about avoiding iatrogenic cervical deformities. These are my different disclosures. Cervical deformity is not uncommon, and when you speak about cervical deformity, the vast majority of them are cervical kyphosis. Of the different causes of cervical deformity, the most frequent cause is iatrogenic, and this is partly because of the delicate balance that is needed for the cervical spine to function appropriately. The normal cervical spine has a lordosis of about 14.5 degrees, but there's a substantial range of normal. The weight-bearing axis in the cervical spine is posterior to the vertebral bodies, unlike the thoracic and lumbar spine, and the load transmission has almost 2/3 of the force or load through the posterior columns. This results in a situation where the cervical spine is particularly predisposed to developing deformity with iatrogenic injury. And this can occur through the removal of the posterior tether. It can occur through compromise of the facet joints. It can be caused by muscular denervation. It can be a failure to appropriately recognize preoperative kyphosis. It can be related to radiation damage, neuromuscular disease, or even rheumatological conditions. This is a patient with advanced cervical degenerative disease, and the previous cervical fusion at C1-2 likely was the predisposing factor to the development of this kyphotic deformity. Now, what happens is, as you begin to lose sagittal alignment, the axis of the gravity line shifts anteriorly. The muscles must be able to bear a greater proportion of the load. If this does not happen, the patient develops progressive kyphosis. One of the difficulties with kyphosis is that the spinal cord becomes draped over the kyphotic segments, and this increases the compression of the spinal cord itself. And this nice study by Justin Smith showed that myelopathy scores are impacted by the alignment. When we generally talk about cervical lordosis, we're talking about C2 through C7, but there is normally a significant amount of flexibility between C1 and C2. And as the spine changes in alignment, there's also changes in the gravity line that is present. Now, it's been shown that there's a wide range of, quote, normal alignment, which ranges from significantly kyphotic to almost straight spine to slight kyphosis to substantial kyphosis. And only about 70% of the spine will have lordosis in any form. So what's been happening is, how is it that some people tolerate loss of lordosis and other people really do not? And this is related to the gravity lines best measured in the alignment between C2 and C7. This wonderful study led by Chris Ames shows a very high correlation between the increasing C2, C7 SVA showing cervical malalignment and the impact on disability. And as adults become progressively more disabled, as the cervical spine becomes more deformed. Now, there's an interplay between the cervical spine, the thoracic spine, the lumbar spine, and it's been shown, however, the greatest correlation is the correlation between thoracic kyphosis and the amount of cervical lordosis that is present. And this is due to the fact that the T1 slope serves as a similar structure as the sacrum does for the thoracolumbar spine. And those who have a small T1 slope usually have a small amount of cervical lordosis, and those with a big T1 slope need a substantial greater amount of cervical lordosis to be present, as you can see. And if this does not occur, the gravity line shifts anteriorly, and the posterior cervical musculature needs to do more work and more likely to have significant symptoms. The head itself is a substantial structure. It weighs about 4.5 kilograms. And as you become out of alignment, the work that the rest of the body, particularly the cervical and upper thoracic musculature, has to do becomes substantial. As you can see by these cantilever loads in this picture by Chris Ames, showing the impact on one of his patients. So one of the things to realize that there are some compensatory mechanisms. The articulation between C1 and C2 allows a substantial degree of motion. And this is shown in this patient of mine who came in with horrific intractable neck pain after multiple thoracolumbar surgeries. And the fact is, as you can see, that much of her symptoms are related to hyperextension in the cervical spine. And by correcting her thoracic and lumbar spine, her cervical spine totally relaxed and her neck pain went away completely, showing even though the neck was the principal area of complaint, it's the thoracolumbar spine which was actually the cause of the problem. Now, one of the questions is, where is the deformity? And by assessing the C2 tilt and the T1 slope, you can identify where the true deformity actually exists. In this case, with a high C2 tilt and a low T1 slope, we recognize that this is a cervical deformity. In this case here, when there's a low C2 tilt and a high T1 slope, that we realize that this is a thoracolumbar deformity. And then lastly, in this case where both of the values are high, this is a deformity involving both the cervical spine, the cervicothoracic junction, and the thoracic spine. Now, Chris Ames did a wonderful job of identifying all the different factors associated with and classifying deformity. Now, when we're talking about causes of cervical deformity, the number one cause is the age of the patient. And what has been shown as the younger the patient, the greater the impact of disrupting the posterior tension band. It has been shown that children under 6 years old, they have the highest incidence of the development of significant deformity and mostly cervical kyphosis with a laminectomy. This is a patient that I treated years ago, a 3-year-old with neurofibromatosis who underwent a multi-level cervical laminectomy at the age of 2, now with progressive myelopathy, difficulty using her hands and walking, and you can see the severity of the deformity. It's also complicated by very little bone stock in which to fix this. In this particular case, I did brief preoperative traction followed by corpectomies and placement of a fibular autograft and then treatment. In adults, the causes are usually pre-existing kyphosis, removal of the lamina and ligaments at multiple levels, facetectomies greater than 50%, and the principal one, which is really avoidable in many cases, is removal of the semispinalis cervicus musculature. This is a patient who had again had a previous cervical thoracic junctional procedure. This over time became rigid and required this treatment to be able to do it. You can see it spans the entire distance of the semispinalis cervicus musculature. So for the principles of evaluation, management, and treatment, the number one should be prevention. If we're going to do surgery, neural decompression, reconstruction of the anterior column, followed by reestablishment of a posterior tension band, restore sagittal balance, and then provide long-term stability becomes important. The bigger the abnormalities, for example, this lady with severe rheumatoid arthritis, and you can see the severity of the deformity present, including the subluxation in the upper cervical spine and the treatment that's required for this type of deformity. Now, one of the realization factors is that patients with cervical deformity frequently are frail, and going and improving their frailty before surgery becomes very important. At Duke, we follow a routine laboratory and bone quality assessment, and these includes a variety of different laboratory studies to help assess bone quality and assess factors that can be improved prior to surgical intervention. One of the principal things to consider is the impact of the neck extensor muscles. The semispinalis cervicus is 37% of neck extension strength. And removal of the semispinalis attachment on C2 has been shown in laminoplasty to markedly increase the risk of a kyphotic deformity. Similarly, as many surgeries are now done involving the cervicothoracic junction, the origins from the transverse processes of T1 through T6 can lead to similar type deformity, as you can see in this particular case. So in general, there are many of the iatrogenic cervical deformities are preventable. It requires a thorough assessment of the anatomic and biomechanic and physiological factors. An individualized approach is needed to obtain preoperative optimization, planning to go and emphasize good sagittal realignment, devising surgical strategies that emphasize long-term spinal stability. The complications in debilitated patients can be high, and sometimes even the best intentions can lead to bad outcomes.